Professor Lobna.
Good evening, everybody. It's my honor and pleasure to introduce a new topic in medicine called personalized medicine. Okay, thanks to Rush giving us the chance to share this experience. Personalized cancer therapy and the value of comprehensive genomic profiling. Does one size fit all? The answer is definitely no. So this is the philosophy of personalized cancer therapy. In 1999, we treated the patient, the tumor by the organ or the site, breast, certain chemotherapy, colon, another protocol of chemotherapy, ovary, a third protocol of chemotherapy with the same protocol to the same site, to the same location of cancer. Then understanding the evolved into discovering the biochemical responsible for that in 2010. With discovery of targeted medicine related to biomarker, and in 2020 with revolution of molecular biology, and subsequently this biomarker led us to identification of precision medicine with NGS. MD Anderson personalized cancer therapy strategy. The strategy of personalized medicine is to deliver or to tailor treatment to each patient according to his unique cancer genomic profile. As we all, as an oncologist, know that excessive exposure to virus, bacteria, pollution, radiation, parasite, etc., lead to genomic alteration. Thanks to God, vast majority of this damage will be repaired spontaneously, but rare one continue with this alteration lead to carcinogenesis. To know how the alteration lead to cancer, let us to identify the healthy pathway gene. Yes, DNA after transcription to pass to RNA, RNA with translation to protein, and the protein pass in pathway proliferation or survival. As you see, multi-gene step. In healthy individual, unaltered, unmutated gene produce protein which has a specific function. When gene are altered or mutated, resulting in protein produced can sequence structure and function this mutilation, which lead to uncontrolled survival or uncontrolled proliferation. 4 classes of genomic alteration can drive tumor growth: base substitution, insertion and deletion, copy mutation, or rearrangement. The best example for base substitution as BRAF V600E, and insertion and deletion like exon EGFR 19 deletion, amplification like HER2, and RET representing the last type. This is how base substitution happened. It is just one base in DNA replaced by another, translated into different protein, different pathway. For clinical example for this type of base substitution is EGFR T790M associated with resistant to EGFR tyrosine kinase inhibitor, and EGFR L858R or L861Q associated with sensitivity to EGFR TKI, BRAF associated with sensitivity to BRAF inhibitor. Insertion or deletion, the right side representing insertion, the left side representing deletion, and the clinical example again is exon 19 deletion in EGFR. The last class of alteration is copy number alteration, either by amplification or homozygous deletion. The best example of HER2 amplification in breast cancer associated with sensitivity to Herceptin and anti-HER2. And another example of CDKN2A loss in breast melanoma and the broader result in loss of tumor suppressor gene and inactivation of retinoblastoma and B53, and is associated with potential sensitivity to CDK4/6 inhibitor. Rearrangement, gene A space gene B, so fusion with gene A and B lead to alteration. The best example is RAT fusion with sensitivity to RAT inhibitor. This is the beauty of genome. In just 10 years ago, we have just one treatment for lung cancer. Now we have panel directed by alternation, actionable alternation genomic study. So the treatment of cancer become complicated. It started with targeted inhibitor and passed to cancer immunotherapy, or even conjugation of more than actionable treatment related to more than one alteration. The key role in genome is studying the role of diagnosis of cancer. It started with immunohistochemistry in 1923, passed to fish in 1982, and then 1985 PCR was introduced, and Sagner in 1977, first generation sequencing, and it was a great success with NGS in 2004. Yes, this represents the revolution in diagnosis of cancer. This is translated to impact on clinical management. As you see, with immunohistochemistry, the impact on clinical management was limited. And now with hybrid capture, genomic alteration, we have a lot and increase in impact of clinical management. This is a comparison between immunohistochemistry, which is considered as a subjective technique, to in situ characterization, to PCR, to sequencing. first generation sequencing, and the end of comprehensive genetic profiling, with all positive impact on clinical situation of cancer management. This is a comparison between hotspot multigene NGS and hybrid capture comprehensive genetic profiling. In comprehensive genetic profiling, it gave me the whole picture of genome in cancer patient, compared to hotspot limited sequence in certain type of gene. Comprehensive genetic profiling can identify many oncogenic driver and actionable treatment across all the tumor, as you see, nets of tissue, head and neck, skin, lung. Lung is a highly mutagenic cancer. What is the impact of comprehensive genomic profiling in detection of actionable alternation? In comparison with PCR, NGS identified 12% more patients with resistance associated with KRAS. In BRAF, we miss 37% with regular or conventional methodology of immunohistochemistry, or even with PCR. And 17% again in exon 19 deletion with NGS. This is a beautiful trial, Memorial Sloan Kettering Cancer Center, studied 31 tissue of lung adenocarcinoma, and unfortunately by conventional or rather than NGS, no mutation was detected. The same group of patients, the same tissue by NGS discovered 65% clinical mutation relevant. That's why NCCN guideline version 3 2020 endorsed NGS as a part in adenocarcinoma and squamous cell carcinoma of the lung. Also in cancer colon, not only MSI, not only KRAS, RAF, but a lot of mutation, even HER2 discovered in cancer colon. Yes, another benefit in ovarian cancer and primary peritoneal carcinoma, not only BRCA1 and 2, but a lot of mutation discovered in this group of patients. ESMO issued the first recommendation for the use of NGS in advanced cancer. A very important piece of information here, ESMO recommended to use off-label drug produced by genome profiling. Moscato trial, this trial, inclusion criteria, as you see, 75% was the pediatric population, but more than 1,000 population was adult, performance status, minimal one treatment line, should had a measurable disease to measure the response. Primary endpoint, progression-free survival using targeted treatment selected by molecular profiling, which considered as PFS2 compared to progression-free survival for the most recent treatment, PFS1. If the ratio, the significant ratio is more than 1.3. This is the description of the study. It started with 1,110 molecular NGS was actionable in 410, received matched treatment only in 199. Outcome, PFS2 to PFS1 ratio was more than 1.3 in 33% of patients. To translate this into clinical, 33% of patients treated with actionable treatment related to genetic profiling got benefit. Median overall survival was 11 months. PREDICT trial, previous treated refractory lethal metastatic cancer, stage 4. No two molecular profile was done. This is a trial design. And this is the alternation detected. Percentage of actionable. Actionable means there is targeted therapy, can act with the alternation in the gene. If the matched score more than 50, the patient got benefit. As you see on the left side, with matched score more than 50, 45% of patients achieved either complete or partial remission, and around 30% was a stable disease for more or equal 6 months. But if the matching score less than 50, the clinical benefit drop. This is translated into progression-free survival, as you see the gapping between the matching score more than 50 dotted with black with blue color versus matching score less than 50 in yellow color. Also translated in overall survival with 56% reduction in death. So, what is the value of comprehensive genomic profiling? First step, when the patient is diagnosed with cancer, can help us genomic profiling as we face a rare cancer with different, with no guideline, standard guideline. So for those patients, develop a treatment plan, prevent prescription of contraindicated therapy, avoid trial and error treatment, inform a prognosis with hematological malignancy. This may guide decision around transplantation or other invasive treatment. Another scenario, add progression and relapse. When the patient progresses on therapy or his or her cancer recur, genomic profile can highlight potential next step, uncover resistant mutation or new alternation, evaluating cancer therapy, report biomarker that may predict response to immunotherapy. In a refractory patient, when the patient status failed to improve after multiple lines of treatment, CGP may help uncover new option of treatment, clinical trial, therapy intent for other cancer types. As a conclusion, personalized cancer care is the future of oncology. Cancer is a disease of genome, not organ-based disease. There are 4 types of genomic alteration, as mentioned previously. Traditional molecular genetic diagnostic approach might miss genomic alteration. NGS-based hybrid capture genomic profiling enable detecting all the genomic alteration across and related gene, thus enable better cancer treatment. Evolving evidence regarding the value of genomic profiling for metastatic cancer patient after many lines of treatment. NCCN guideline endorsed the use of progenome profiling per first-line treatment for lung cancer and in other tumor type. And thank you.
Thank you, Professor Dr. Lubna, for your elegant presentation on precision medicine. And now we have to close this session for the sake of time.